It is my pleasure to introduce my friend Kenyush Kashani. He is going to discuss critical care nephrology literature review.
Thank you very much, Mr. Chairman. Thank you, Ravi, for invitation. As I wanted to save time, I decided not to breathe. I did a single arm, one with N of 1 trial today, so I was okay. So please keep calm, enjoy the presentation. Even my color starts changing. I have no relevant disclosure regarding to this activity. This is by no means going to be in-depth review of these papers. This is just an overview of what happened in 2023. Epidemiology-wise, there was a great study by Dr. Zarbach group. It's a prospective cross-sectional study of 30 countries, mostly in North America. 10,000 patients of patients who underwent surgical procedures with incidence of acute kidney injury of 18%. Primary outcome was post-operative acute kidney injury within 72 hours after surgical procedure. As you can see, there is a significant number of patients that actually had KDIGO stage 1, mostly diagnosed with serum creatinine. And the more intensity of acute kidney injury, there is more persistent acute kidney injury, which is defined differently from what Dr. Koiner has outlined in literature, is only 48 hours is called persistent acute kidney injury. So higher stages of acute kidney injury was associated with more persistent acute kidney injury. 2/3 of these patients had stage 1, about 1/4 had stage 2, and only about 10% had stage 3 acute kidney injury. When they looked into mortality, as you can see, the mortality progressively increases with stages of acute kidney injury, and particularly when stage 3 is associated with diagnosis of acute kidney injury based on both criteria of acute kidney injury, serum creatinine and urine output is significantly higher mortality. Mortality goes from 2% in stage 1 all the way to 42% in the stage 3 when both criteria was used. There were a significant number of factors that was found to be associated with acute kidney injury. Among those, obviously, some baseline characteristics related to surgical procedures, those that were associated with emergency surgery or they had longer time of surgery, they had higher risk of acute kidney injury post-operatively. Also, cardiovascular surgery and abdominal surgery were associated with higher risk of acute kidney injury. Moving to nephrotoxicity, this ACORN trial was a very large randomized clinical trial based on all the observational trials that indicated piperacillin tazobactam could be potentially associated with acute kidney injury. They enrolled 2,600 patients, randomized them between cefepime versus piperacillin tazobactam, about 1,200 to 1,300 patients in each arm. As you can see, each arm received the drug of assignment, although a small percentage of each arm received additional antibody, the other arm antibody, or crossed over completely to the other antibiotic. Primary outcome was acute kidney injury and death by day 14, which was not significantly different. Same for major adverse kidney events in day 14, was not different between the two groups. Interestingly and kind of knowingly from the past, delirium and coma-free time was higher in piperacillin tazobactam, as there is significant literature indicating cefepime could be associated with delirious state and coma. In exploratory outcomes, there was no difference between the two. Indeed, cefepime was associated with slight increased risk of need for dialysis in day 28. In subgroup analysis, there was no subgroup that did show any difference in acute kidney injury, nor major adverse kidney events in day 14. The only thing that was positive was delirium. Can I go back? Delirium and coma-free time with piperacillin tazobactam. Thank you. Next, nephrotoxicity. One of the important questions is use of ACE inhibitor and ARB after acute kidney injury. This is a VA cohort of 55,000 patients. Obviously, 97% of them were males. They were followed for 10 years, and death through these 10 years happened in 2/3 of these patients, with a median time to death of about 2.5 years. About 60% of them received ACE and ARB within the first 3 months of after admission for acute kidney injury. So the way that they ran this study, they identified patients that admissions that patients develop acute kidney injury. To enroll patients, they had to have at least 2 visits with baseline creatinine measures 18 months prior to admission, so they can ascertain what the baseline creatinine was. Then during admission, they measured baseline characteristics, and the 3 outcomes of mortality and the monitoring for ACE inhibitor and acute kidney injury recovery, and then time to event analysis for recovery. Obviously, survival was significantly better when ACE and ARB were used in comparison with those who did not start ACE and ARB. Hazard ratio for mortality was 25%, 0.74, indicating 25% less risk of mortality when ACE and ARB were used. Particularly among those with diabetes and proteinuria, the earlier initiation of ACE and ARB was associated with less hazard risk ratio of mortality, means that the earlier initiation is probably more beneficial. They also looked into relationship between mortality and renal recovery in the setting of ACE and ARB. As you can see, there are 2 different groups that can be easily visible. Those who were on ACE and ARB, regardless of recovery, they had better survival in comparison with those who were not on ACE and ARB, regardless of recovery. When they did hazard ratio and using no ACE and ARB and no recovery as a reference group, recovering that group provided slight benefit of about 10% less risk of mortality, but 30% less risk of mortality when they were on ACE and ARB, regardless of recovery of acute kidney injury. So initiation of ACE and ARB probably is beneficial in patient population. Obviously, 3% were female, therefore, kind of this needs to be further evaluated. Going to biomarkers and models, as you know, ADKI group suggested stage 1S acute kidney injury, which is when you do not have clinical acute kidney injury, but biomarkers indicate injury. That is a group that is interesting to follow. FROG ICU was a prospective observational study of all ICU patients to see what are the risk factors for their mortalities. 1,800 of those patients had biosamples gathered, and 1,100 of them did not have acute kidney injury at the beginning. 28% of them died. They measured multiple biomarkers: plasma urine NGAL, plasma urine cystatin C, plasma proencephalin, urine liver fatty acid binding protein, and urine peptidomics. And this is the diaspora of all the biomarkers that they measured and those that became positive. Now, those who did not have acute kidney injury and did not have any sign of injury biomarker positive, they had about like 18 to 22% mortality. However, those with acute kidney injury stage 1S means that they still do not have rising serum creatinine, but they had signs of damage. Mortality increased to up to 47%, which was very comparable to those who actually had acute kidney injury. Other finding was that the more number of biomarkers become positive, the higher mortalities, and this is dose-response relationship. If you have 7 biomarkers positive, then your mortality is as high as 70%. When they did subgroup analysis based on the number of biomarkers positive, obviously the higher number of biomarker positivity was associated with higher mortality. Among those with no acute kidney injury, this relationship lasted. However, among those with acute kidney injury, means that serum creatinine is increased, the impact of injury biomarkers was not as visible. You needed to have 7 biomarker positive in order to see statistically significant increased mortality. Now, urea in prediction of mortality among our ICU patients. This is a post-hoc analysis of A4 protein trial, which was a randomized trial to assess high protein diet intake versus standard of care. As you can see, by day 6, urea starts rising in high protein diet and lasts up to day 12. This study was negative, so there was no association of high protein diet and mortality among these patients. However, urea found to be very excellent predictor of mortality among this patient population, with 30% higher risk of mortality when after adjustments when urea is elevated. Moving to fluid type as a drug, So this is a systematic review and meta-analysis of a perioperative randomized clinical trial, 38 of them, with about 3,800 patients included. Obviously, those who received balanced solutions had higher bicarbonate and lower chloride, but this did not translate to clinical outcomes. So mortality was the same, and need for dialysis was the same. So using normal saline or balanced crystalloids among surgical patients may not be associated with worse clinical outcomes. Pediatricians did it again. They showed us how we have to do this. This is a great study in pediatric ICU in India, randomized clinical trial of 700 patients, average age of 5 years. These children received 30 cc per kg of fluid, and for resuscitation over course of first day receive about 100 cc per kg. These patients were randomized between normal saline versus balanced multi-electrolyte solution. There was not significant differences in metabolic panel, nor differences in need for vasopressors or length of stay. Chloride was significantly higher in normal saline as expected. And then in these individuals, because these children had very small volume distribution, fluid normal saline was able to show significant increase in risk of acute kidney injury. So acute kidney injury in normal saline group was 33%, or progressive acute kidney injury, versus 21% in balanced solutions. This is Bell's fluid trial. I found it very interesting trial. This is the difference between plasma-lyte versus normal saline among patients who are receiving deceased donor kidney transplant with a primary outcome of delayed graft function. So this was a pragmatic, double-blinded, randomized clinical trial in 16 hospitals with 800 patients, one-to-one assigned to plasma-lyte versus normal saline during operation up to 48 hours with primary outcome of delayed graft function. As expected, chloride, bicarbonate, blood pH, and sodium was different between the two arms. However, there was no difference in potassium, urea, hemoglobin, and body weight. When they looked into urine output, after all adjustment, it seems that those who received balanced crystalloid, they generated additional liter of urine through the first day. Through the first 48 hours. It means that using balanced crystalloids probably allows these new kidneys to start working better. There was no difference in serum creatinine between the two arms. All the secondary outcomes were even between the two groups. However, delayed graft function, as defined by number of dialysis within the first initiation of dialysis within the first 7 days, was significantly lower when balanced solutions were used during operation up to 48 hours. In subgroup analysis, almost all subgroups showed benefit when balanced solutions were used as far as delayed graft function is concerned. Also, in raw number of hemodialysis, although balanced crystalloids group had higher number of dialysis, after all adjustments, in incidence rate ratio showed 25% decrease in number of needed dialysis for these patients, and hazard ratio of independence from dialysis, time to independence from dialysis, was in benefit of balanced crystalloids after adjustment for multiple factors related to this patient population. Now, following all this information about volume distribution and amount of fluids, investigators of BASICS trial, which was a trial, 11,000 patients in Brazil, that was a trial two by two factor to assess impact of balanced solutions versus normal saline and fast versus slow delivery of fluid. They did some post hoc analysis. About 10,000 patients were enrolled, and they divided based on institutions. They found different centers use different practices. Some of the centers actually deliver a lot of fluids. Overall, there was no difference between balanced solution and normal saline in mortality, even those who received more fluid. However, when they divided patients between elective surgery, not septic patients, or septic patients, it seems that when septic patients reach a little higher fluid intake, more than 4 liters, there is a significant risk of higher mortality when they use normal saline. So there is a signal for benefit in balanced solutions in high fluid intake among septic patients. As a matter of fact, odds ratio and also absolute risk difference of mortality among patients with sepsis when they receive balanced crystalloids are lower when they receive more fluids of about 4 to 6 liters. And that also was replicated when unplanned procedures or septic patients among institutions that delivered a little more fluid, they showed significant improvement in mortality when balanced crystalloids were used in comparison with normal saline. So volume of distribution matters, therefore higher amount of fluid is needed in order to see any signal. How about fluid dose? This is a systematic review meta-analysis, including new RCTs with, to assess high versus low volume intake during resuscitation with 3 primary outcomes of all-cause mortality, severe adverse events, and quality of life. None of the major trials reported quality of life data, so they ended up reporting all-cause mortality and SAE. There were 9 randomized clinical present. With the 4 new ones, they ended up 13 studies being enrolled in this study. What they found was that some of the studies were low risk of bias, including Classic and Clover trial that was published earlier this year and last year. And then some studies were high risk of bias. All groups had low heterogeneity, and they showed no benefit about mortality. They also did trial sequential analysis. This is really interesting analysis. This is when you do systematic review and you want to see if there is any need for additional randomized clinical trial or not, you do this type of analysis. This accounts for type 1 and 2 errors in clinical trials. So there are 4 zones, as you can see in this figure. Zone A and D are the time that the evidence of benefit or harm is so significant that additional trial likely does not change the outcome. Area C is futility zone. If when additional randomized clinical trial may not improve the results of the study from futile results. Area B, however, is when you still require the additional randomized clinical trial to get to that point. So for all-cause mortality in this particular systematic review, as you can see, Z-curve is already in a futile zone. So additional randomized clinical trial to show high volume intake versus low volume intake, making any difference in all-cause mortality with a relative risk reduction of 15% would be unlikely. However, for severe adverse events, as you can see, there is a trend toward improvement in outcome when lower amount of fluid was used. It has not reached a point that we can be certain, so we need additional studies, but there is a significant signal that potentially not using significant amount of fluid is beneficial, while using standard versus low fluid does not provide any mortality benefit. Now, moving to de-escalation use of diuretics, this is a randomized clinical trial of patients with acute decompensated heart failure, open label, pragmatic trial of 60 ICUs in the United States, 2,800 patients enrolled, and primary outcome was all-cause mortality in 30-month follow-up. And this trial was designed in a way that the patients were randomized between torsemide and furosemide for management of ADHF patients. There was absolutely no difference between this patient population as far as the primary outcome. And when they looked into not only 30-day mortality, they looked into 1-year mortality and readmission, there was absolutely no difference between the 2 arms. So using torsemide versus furosemide depends on which one is available in your institution. This is a retrospective study using MIMIC-3 data. 5,500 patients were enrolled with primary outcome of ICU death to assess the role of loop diuretics when it's used after cardiac surgery in and among those patients that have acute kidney injury after cardiac surgery to see if that is associated with death. What they found was that use of loop diuretics is associated with significantly better survival among all patients in the cohort, even when they did inverse proportional weighing to account for selection bias and also account for missing data, that relationship continued. So there is significant benefit using loop diuretics among patients with cardiac surgery associated AKI. This is a post-hoc analysis of ADVOR trial. ADVOR trial was a randomized clinical trial to assess impact of acetazolamide versus placebo in decongesting patients with acute decompensated heart failure. The purpose of this post-hoc analysis was per se looking into how presence of chronic kidney disease impacts this relationship. As you can see, median GFR among these patients in ADVOR trial was 40 ml per minute per body surface area, which classifies majority of patients living in stage 3B. As a matter of fact, when you look into the division between the different chronic kidney disease stages, majority of patients participating in the study were stage 3B or stage 4. All patients had some benefit as far as decongestion, but it seems that benefit is slightly more is in the stage 3B and stage 4. So the more CKD patients benefited from additional acetazolamide in addition to loop diuretics in this patient population. Total natriuresis was higher regardless of GFR when acetazolamide was used. However, this increase in urine output was natriuresis was significantly more when you had a GFR less than 40 ml per minute body surface area. So CKD patients actually benefit from additional acetazolamide more than patients who do not have CKD. The same finding was noted in urine output. So urine output is more in patients with CKD. At the same time, creatinine increasing in these patient populations. Do we care about creatinine or worsening renal function when we are diuresing patients with acute decompensated heart failure? What they noticed was that the two group was very visible. Those who dried out, decongested using acetazolamide and Lasix, those who, and regardless of worsening renal function, they had better outcome. Those who remained congested, so diuresis did not work, regardless of worsening renal function, they had worse outcome, worse survival. So the purpose of acute decompensated heart failure is not necessarily worsening kidney function, it is decongesting them. This is use of hydrochlorothiazide and furosemide for acute decompensated heart failure, a double-blinded, placebo-controlled randomized clinical trial of 230 patients with primary outcome of weight loss and dyspnea score in 72 hours. Regardless of how they looked into dyspnea score, visual analog, or Likert scale, there was no difference between hydrochlorothiazide use or placebo. However, for each 40 milligram of furosemide, use of hydrochlorothiazide was associated with significant more weight loss, which is essential when we manage patients with acute decompensated heart failure. What they found was patients with lower BMI, older patients, patients with atrial fibrillation, and lower systolic blood pressure benefit from hydrochlorothiazide more. Patients with very more advanced CHF or diastolic failure, they benefit from hydrochlorothiazide more. It is known that thiazide diuretics, when GFR is very low, may not work really well. So that's why when GFR CKD progresses, we switch from hydrochlorothiazide to loop diuretics, and that was observed here as well. So estimated GFR more than 30 was associated with better outcome, and also for loop diuretics, higher dose of loop diuretics was associated with better impact on hydrochlorothiazide. Means that we don't need to start hydrochlorothiazide at the very beginning. Those who needed higher dose of diuretics, loop diuretics, they can potentially benefit from added hydrochlorothiazide. There was no difference in mortality or 90-day readmission among this population. How about AKI management? This is really interesting systematic review meta-analysis of 13 articles and 16,000 patients to see the impact of care bundles on outcomes of acute kidney injury, including 5 randomized clinical trials, 8 non-randomized clinical trials. What they found was that for major adverse kidney events, regardless of using biomarker in these care bundles or not, there is significant improvement in major adverse kidney events of about 30%. When they looked into acute kidney injury incidence, they found similar finding. Regardless of use of biomarker, there was significant decline. And when they only used randomized clinical trial, MAKE was lower, about 45%. Acute kidney injury incidence was lower by 45%. However, renal replacement therapy and all-cause mortality did not differ based on care bundles. How about renal replacement therapy modality? Modality of renal replacement therapy between intermittent hemodialysis CRT is an important question. This is post-hoc analysis of a START-AKI trial, which was a trial, large trial of a pragmatic trial to assess accelerated versus watchful waiting initiation of dialysis. 600 of these patients received intermittent hemodialysis and 1,600 received CRT. Primary outcome of this post-hoc analysis was death or dialysis dependence in 90 days. As you can see, the primary outcome was significantly positive. 19% in a benefit of CRT. CRT patient had 19% less risk of dependence on dialysis and also survived. But when you divide this composite outcome to this component, there is no benefit in mortality. Most of benefit comes from dialysis independence in 90 days. Also, ICU-free days and hospital-free days was more when CRT initiated instead of intermittent hemodialysis. Regarding anticoagulation, we are always worried about the use of citrate, regional citrate anticoagulation among liver patients. This is a very small trial, but I think that this is a potentially hypothesis generating for future studies. This is 89 patients randomized of liver failure patients randomized in two groups, no anticoagulation versus regional citrate anticoagulation. And as you can see, the primary outcomes were met. Filter lived longer with more lifespan. However, those liver patients, if the cutoff of citrate level was 0.85 millimole per liter, most of them developed citrate lock and citrate accumulation throughout the study, 72 hours of study. Majority of them had very lower ionized calcium in comparison with those no anticoagulation. Also, ratio between total to ionized calcium was significantly higher among those who received citrate. This is all we are worried, citrate lock or citrate accumulation. However, there was no difference in pH, no difference in base excess, and no difference in mean arterial pressure. As a matter of fact, when you look into that, there is no significant differences in clinical outcomes, including need for vasopressors or increasing vasopressors, length of ICU in a stay in ICU in a hospital, and 28-day mortality. You may say this may be type 2 error, as the size is so small, cannot detect differences in outcome, but we safely use citrate in a lot of our patients and adjust the citrate dose based on total to ionized calcium range. With that, I thank you for your attention.